up where we left off because we were talking about fluid, electrolyte, acid-base balance. We covered water, deficit and excess. We talked about edema, and then we talked about sodium and potassium. So the last of the electrolytes that I think is important enough to kind of go over is calcium. And while calcium problems are not particularly common, when they're present, they're a big deal because calcium is one of the critical ions for normal functioning. I mean, if your calcium level is too high, you're headed towards dead, and if your calcium level is too low, you're headed towards dead. So, and calcium has this additional kind of unique feature, and that is the body has a huge store of calcium present all the time in the bones. So unlike sodium and potassium, where we take in sodium and potassium and we excrete sodium and potassium all the time, calcium is ingested in food and it's excreted in urine and feces, but it's also stored in the bone. So none of the other electrolytes that we've talked about had any kind of a storage form. So calcium is controlled by multiple hormones, but the two major players are parathyroid hormone that come from the parathyroid glands, which these are glands that are next to the thyroid gland. There's two on each side that sit kind of inside the lateral edges of the thyroid gland. And then calcitonin are the two hormones that control. So when calcium levels fall, parathyroid hormone is secreted because parathyroid hormone increases the calcium absorption from the digestive tract and also prevents calcium release at the kidney into the urine. So calcium is held onto. And also parathyroid hormone encourages calcium to be released from bones. So it's uncommon to have calcium levels that are low unless there is a problem with the parathyroid hormone. All right. So because bone contains calcium and because bone is very much alive, new bone is being laid down every day and old bone is being disintegrated or dissolved in this constant remodeling process that goes on in the bone. It means that the calcium that's locked up in bones can be released for use by the body to do other things under the control of PTH or calcitonin, as we'll see more of later. The other major player is vitamin D. Vitamin D is sort of a unique vitamin because we can make it. Typically vitamins are things that we have to have in our diet by definition. But we can make vitamin D, but only when we are exposed to enough UV light. And some of that depends on the kind of melatonin you have, or melanin rather, that you have. But in any case, we can make it, or we can ingest it in food, which is the more common way that vitamin D is gotten in. And the form that's made in the skin, or the form that is ingested in food, is not active in our bodies. It has to be activated by the kidney before it can actually do its thing. And what it does is it improves calcium absorption from the digestive tract, and it also prevents calcium being lost in the urine. So it mimics in some ways what parathyroid hormone does. And for some reason I didn't say what calcitonin does. Calcitonin works in the opposite direction. So an increase in PTH causes an increase in calcium levels in the blood, and an increase in calcitonin causes a decrease in calcium in the blood. The old mnemonic is calcitonin tones down calcium. So it turns it down. Parathyroid hormone and vitamin D both turn calcium levels up. All right, so that's the normal case. So let's look at a little when things go wrong. One more point, calcium and phosphate. Phosphate is an important electrolyte in the body, although we're not going to talk about it this time. It plays a role in the energy molecule, ATP. That P is phosphate, adenosine triphosphate. Phosphate plays a major role as a buffer to prevent pH changes. And also, next to calcium in the bone is phosphate. It's calcium and phosphate together that make the mineral part of the bone, or the concrete, so to speak, the hard stuff. And they have this relationship where as calcium goes up, phosphate goes down. And the opposite is also true. So if you have a disease state where calcium is high, phosphate will be low. If you have a disease state where calcium is low, phosphate will be high, because they have this reciprocal relationship. Every once in a while, in the rare disease, you can have them both be elevated. And one of the reasons the body prevents that from happening is if you have high calcium and high phosphate, they basically make bone in all different kinds of places in the body, because they crystallize. Calcium and phosphate can bind together, and you end up with calcium phosphate crystals in muscle and fat tissue and the skin, and it can be very, very problematic. One more point to note is it's only calcium ion that is active in the body. Calcium that's bound to other things does not participate. So the calcium level that you'll see and be concerned about is the Ca++, is the ion version, because that is what plays a role in muscle contraction and heart contraction and nerve conduction. So calcium does all kinds of different things. We all know it's famous for teeth and bones. That one's easy. It maintains the stability of active cell membranes, so like your nerve cells and your muscle cells. So what we see happen when calcium is either high or low is cells become kind of twitchy. They don't behave right because their membranes are unstable. We all have learned that calcium triggers muscle contraction, both in skeletal muscle, in cardiac muscle, and in smooth muscle, because it's calcium's interaction with those sliding filaments that actually make contraction happen in the first place. And then calcium is a cofactor in lots of different chemical reactions in the body. Of particular note is the clotting cascade. So if their calcium level is low, the patient won't clot, because without that calcium, the clotting proteins don't work right. So that's yet another problem with calcium at least being too low. All right. So hypocalcemia we define as being below 4 milliequivalents per liter. The normal calcium level is 5. So similar range as potassium. Some causes, hypoparathyroidism. Those parathyroid glands are literally buried in the thyroid gland itself. So hypoparathyroidism used to be very common when thyroid glands were removed or were surgically or through radiation damaged, because the parathyroid glands would get damaged too. Now this is less common because those kinds of surgeries aren't being done anymore. But if you don't have parathyroid hormone, there's not going to be a response to a low calcium level. So the calcium levels have to be monitored externally in another way. Malabsorption. There are certain diets and certain changes in the intestine, like inadequate vitamin D, that can prevent calcium that's ingested from being absorbed. So it's one of the reasons why vitamin D is so critical is without it, we don't absorb calcium very well, which is why it's added to things that have calcium in it, like milk and orange juice. All right. A low serum albumin. Albumin helps to bind calcium in the plasma. So if the albumin is low, albumin is one of the plasma proteins, that reduces the free calcium ion that's available. So effectively it makes a hypocalcemia state. Alkalosis also reduces the number of calcium ions because of the as the pH gets higher, calcium wants to be bound to other things. And then renal failure results in retention of phosphate. And because of this relationship, if phosphate is high, calcium will be driven down to prevent that crystallization. So we get low calcium levels with that as well. Some effects. Low calcium in skeletal muscle causes irritability. And this one is the one that's counterintuitive. You'd think if the calcium levels were low that muscle wouldn't contract very well. But that isn't the response we see. Instead, we see that the muscle gets irritable, so it's quick to contract, and it's is prone to tetany, or that locked contraction, you know, like lockjaw is an example of tetany. But in the other muscle areas of the body, cardiac and smooth, we see the predicted decrease in activity. You know, we need calcium for the heart to contract. We need calcium for the arteries to stay nice and firm and the right size. So when there isn't enough calcium, we get cardiac conduction delay, possibly arrhythmias, weak heart contraction. And then in the vessels, we get a drop in vascular resistance, which has a tendency to lower blood pressure and therefore increase heart rate. So the effects at skeletal muscle are increased irritability and therefore activity, but at cardiac muscle and smooth muscle, it's just a decrease in activity like you predict. On the other side of things, serum calcium greater than 5. The normal is 4.5. That is your hyperkalemia. We can get this from a number of causes. Cancer will sometimes cause this, and that's because if the tumor is eating away at a bone somewhere, as it eats the bone away, the calcium from that bone is released, and it's outside of the normal controls because it's, you know, it's a tumor that's doing that. So you get a flood of calcium into the blood. In addition, some tumors actually secrete parathyroid hormone, which is kind of a nasty trick for a tumor to do, to be actually secreting a normal hormone. But lung tumors are infamous for this, that they secrete parathyroid hormone, and then what happens to the patient is parathyroid hormone is trying to raise the calcium level, so the bones become brittle. Sometimes you'll get lesions where areas of the bone that have been totally decalcified from the presence of this false parathyroid hormone. Hyperparathyroidism is just that gland, the parathyroid gland, is overactive. This can be from a tumor, either malignant or benign, that's causing too much parathyroid hormone. Immobility has a tendency to increase calcium levels. The classic, if you don't use it, you'll lose it. If you're not stressing bones on a regular basis with weight bearing or exercise, the calcium in those bones leaves and it enters the bloodstream. So you get an elevation in calcium levels. You can take in too much calcium, either with excessive vitamin D. Vitamin D is one of the vitamins that you can have too much of because it's one of the fat-soluble vitamins. Or too many calcium supplements. You know, if somebody's, you know, desperately trying to prevent osteoporosis, let's say, they may go overboard and be overdosing effectively on calcium. Now, typically, the calcitonin system is pretty good at blocking that. In other words, you can take as many Tums as you want, but at some point you're not going to absorb that calcium anymore because it's going to turn the absorption at the digestive tract off. And then there's this weird one, the milk alkali syndrome. Milk should never be taken with antacid because the two of those things together cause the calcium to be absorbed outside of the body's control. So you can end up with an elevated serum calcium level. So if you're going to take antacids, don't drink it with milk. All right. Effects of hypercalcemia. At skeletal muscle, we see the opposite, again, of what you might expect. You'd think too much calcium would be too much activity at the skeletal muscle. But it's the opposite. It causes muscle weakness, loss of muscle tone, decrease in those reflexes. The mechanism for that is largely unknown, but we think it's kind of the opposite of skeletal muscle irritability. It gets lazy when there's too much calcium around, so it's hard to get it to do what it's supposed to. Because calcium is part of how the nervous system functions, it's the trigger that releases neurotransmitters at the synapse. In the CNS, we get symptoms with hypercalcemia, lethargy, stupor, changes in personality. You can get some weird things there. At the digestive tract, anorexia, nausea, it slows the GI tract down because everything's so stiff, so it makes people not hungry. High levels of calcium interfere with ADH, that we talked about last time. So polyuria sets in as antidiuretic hormones effect is blocked. At the heart, we get an increase in contraction strength, but also the higher incidence of dysrhythmias. You know, you're basically getting the heart to work harder than it needs to, and that can trigger an arrhythmia. And then at the arterioles and arteries, that extra calcium is going to make all of the arteries of the body get smaller because the smooth muscle responds to that calcium by contracting. So you're going to have a tendency to have elevated blood pressures all over the body. And then if the hypercalcemia is caused by an elevation in parathyroid hormone, like you would see in some of those tumors that we talked about, you can see bone density fall. Because one of parathyroid hormone's effects is to increase the amount of calcium that's dissolved from the bones. So if you have that go on for very long, there's going to be less and less calcium deposited in the bones, and you'll start to see a decrease in density, looking very similar to an osteoporosis type picture. All right, so that's calcium. Your book goes into some of the other important electrolytes, but those three are the ones that come up clinically most often or are most important. So sodium, potassium, and calcium are the ones I want you to focus on. And then the last of these metabolic disturbances are problems with acid-base balance. So, you know, we all learned in chemistry class that, yeah.
So do we need to know magnesium, phosphate, and fluoride for the test?
No. We all learned in chemistry class that the pH scale goes from 0 to 14, and that's a huge range of acidity or alkalosis. Our bodies are very, very sensitive to pH, so we control our pH within 0.5 of 7.4. So if you're asked on a test or whatever, what's the normal pH of the body? 7.4, give or take, plus or minus 0.05. And you can see how the range, even between 6.8 and 7.8, is death on both ends. So we have a very narrow pH range that our bodies can stand. Anything below 7.4 we call an acidosis, and you'll remember that that means there's extra hydrogen ions around. Anything above 7.4 is an alkalosis, a decrease in hydrogen ions around. All right. So of the two, acidosis is much more common. And that's because even in normal health, our bodies have a tendency towards acidosis. And that's because we produce acid. The biggest producer of acid is carbon dioxide. The mitochondria produce carbon dioxide as they make energy. That carbon dioxide in the body is transformed into carbonic acid, and then it dissociates into bicarbonate and a hydrogen ion. So this equation, maybe some of you who've had me should look familiar. H2CO3, H plus HCO3 minus. Okay, this is one of the most important equations in all of human physiology. So as a refresher, if you take water and carbon dioxide, you get carbonic acid. And at body temperature and pH, that carbonic acid splits into a hydrogen ion and a bicarbonate ion. Now, what makes it so important in the body is we have an organ that can remove CO2, and that's the lungs. So it means that this whole equation can either go this way or go this way, depending on how much CO2 we can take out of the system. So in the lungs, for example, it moves this way. Hydrogen ions are used up, so to speak, as we create CO2, which we then blow off into the atmosphere. So more on that later. This is the most important of our buffer systems. So in addition to carbon dioxide that makes acid here, going this way, many of our other metabolic processes also produce acid. So like anaerobic muscle contraction produces lactic acid. In a semi-starvation state, we produce keto acids that can be used as energy by cells that don't have any. So we have a tendency towards acidosis. So if we have a narrow range of pH that we can tolerate, and we have a tendency to make acids, clearly there have to be some important systems in place to prevent pH problems from occurring. And there are three main systems. The most important are the buffers. A buffer is simply a pair of molecules that can go back and forth between two different compounds or molecules. So a weak acid together with an alkaline salt, they basically can either shift in one direction or shift in the other. So, for example, in this case, the buffer pair are these two, carbonic acid and H plus bicarbonate. This is a buffer. When the hydrogen ion goes up, it can shift this way. When the hydrogen ion goes down, it can shift this way. So what these buffers do, effectively, is they prevent large changes in pH. Because when you have a buffer present, we'll do another one like phosphate. So you can do this to H plus. I think that's right, but anyway. So let's say we dumped a bunch of acid in this system. What will happen is the extra acid molecules will just attach to the HPO4, and it won't cause a change in pH because the actual hydrogen ion concentration hasn't changed. Those hydrogen ions got attached to something. So we've got four main buffer systems in the body. This is the most important, the bicarbonate system. The phosphate system, hemoglobin acts as a buffer, and so do proteins act as a buffer. So you should have heard about buffers in your chemistry class. So if you've never heard that word before, you might want to just review the chemistry there. So that's one way we control pH. Another is using the respiratory system. The faster we breathe, the more CO2 we get rid of. The more CO2 we get rid of, the more this equation is pulled this way. So for every CO2 molecule we breathe out, we lose an H+, as long as there's plenty of bicarbonate, because that's the limiting factor. When this runs out, the H+ just stays no matter how much extra CO2 you breathe out. And then the final master regulator of pH in the body is the kidney. And that's because the kidney can directly excrete hydrogen ions. It can create bicarbonate ions, and it's very effective at getting rid of the organic acids like this that create hydrogen ions in the first place. The pH of the blood usually reflects the pH of the whole body, and that's because hydrogen ions, being the tiniest little ions there are, very easily move between the compartments of the body. All right. Let's see. So because we have these three systems for managing pH, it means that when there's an acid challenge, in other words, when for some reason this goes up, there's lots more hydrogen ion added, the body can compensate to some extent for that. One of the ways it compensates is to breathe deeper and faster, because that pulls this equation this way. Another way it can compensate is to increase the amount of hydrogen ions that are excreted by the kidney to get rid of those hydrogen ions that way. And we can see, so what this makes is we can have a patient who has a large acid load. In other words, they're creating a lot of acid, like we see in diabetic ketoacidosis. They're producing keto acids in large amounts, but they can present with a normal pH. And that's because they're breathing fast, their urine has become very acidic, so they're maintaining their pH, but the system is being challenged. So one of the things that comes up is this idea of decompensation. And we're going to talk about this word again when we talk about heart failure. So decompensation is where whatever mechanisms the body is using to stay normal suddenly don't work anymore. They get overwhelmed. So like at some point, no matter how much we breathe, like I said, we run out of bicarbonate. Once that happens, then you're going to get a sudden and dramatic shift in pH, which can be fatal. So Anytime an illness has developed slowly over time that increases the acid load on the system, you can't just let it go because the pH is normal. You have to fix it because eventually it's going to overwhelm the compensations, and then the person's going to get very, very sick very, very fast because they don't have any way of fixing the pH that's suddenly changing. Okay. So there's 4 kinds of acid-base imbalance. There's 2 respiratory versions and 2 metabolic versions. So a respiratory acidosis is an acidosis, so a drop in pH, that's caused because of respiration. In this case, if you're not breathing enough, your CO2 will go up, this will shift this way, your pH or your hydrogen ion concentration will go up, and that'll make your pH go down. So the classic respiratory acidosis is respiratory failure. You know, somebody has overdosed on an opiate, for example, and they're barely breathing, so their CO2 is climbing, and as the CO2 goes up, the pH goes down. Classic respiratory acidosis. Respiratory alkalosis, also caused by the lungs, but in this case, the patient is breathing too much. So this can be, the 2 most common forms of this are psychogenic, somebody is hyperventilating from emotional reasons, and the other one is mechanical ventilation. If you take away the patient's ability to control their respiratory rate and depth, you have to make sure you're not breathing too much for them. Because if you lower the CO2, you're going to end up increasing the pH, which can have its own effects. And then the more complicated of the 4 are the metabolics. So in a metabolic acidosis, the pH is low because there's acid coming from somewhere else. So it's not the lungs' fault. It's that acid is being dumped into the system somewhere else. So classic ones are diabetic ketoacidosis, again, where those keto acids are the cause. Renal failure, if the kidney can't get rid of hydrogen ions, they're going to build up in the system, so that's going to cause an acidosis. Shock, anytime a tissue doesn't get adequate blood flow, it tends to release acids. Those acids get into the body and create a metabolic acidosis. And the least common of the 4 is the metabolic alkalosis, and this is a non-respiratory cause for a pH that is too high. So probably the most common one of these is early in a vomiting illness, you have ended up putting a lot of hydrogen ions in the toilet. So what's left behind is bicarbonate, and bicarbonate has a tendency to elevate the pH. So because you've lost acid, you become more alkalotic, or you become more basic. Another is excessive antacid intake. So if you're taking in lots of baking soda, you can also cause a metabolic alkalosis. So your book has a pretty good study table. Table 6-9 does a good summary of the 4 types of acid-base imbalance, what the compensation pattern is, and then what you see in the labs on those patients. So I do want you to spend some time looking at that. I think it's complicated enough where it doesn't teach well in lecture. You kind of have to work through it a little bit before you'll get it. So what are the effects of these? Acidosis, there are lots of different effects. But one of the things I want you to tuck away in the back of your mind is that acidosis is serious. You know, anytime you have a pH derangement, that's a very sick patient, even if they don't look sick. You know, because pH is one of the things that will get you dead in a hurry, basically. And that's because the body because it's so sensitive to pH, when it departs from normal, things start to cascade down pretty quickly. So some of the symptoms, small respirations. This is patients who breathe very deeply and very rapidly. And what they're trying to do is use the lungs to get rid of that acid. So the classic patient in DKA is huffing and puffing. They're breathing very fast. And that's because they're trying to raise their pH. And then a urine with a very low pH. One of the classic urinalysis tests is pH. And if you see a very low pH, it probably means that that patient is in compensated acidosis. In other words, they have an acid problem, but their pH may be normal in the blood because the kidneys are working overtime trying to get rid of all that acid. All right. And like I said, alkalosis is much less frequent. I've actually already talked about these things. For all of the metabolic imbalances, so sodium problems, potassium problems, calcium problems, even magnesium chloride, all those things we talked about, you have to be careful because it's easy to think you know what's wrong so you can fix it. In other words, well, the patient's sodium level is too low. Well, let's give them extra sodium. And you cannot think like that with these imbalances because you can make a much bigger mess with that approach than you can with the better approach, which is here, which is you've got to identify what the underlying problem is. Because until you know what the cause is, anything you do is likely to make it worse. Because sometimes the problem is that it's really a deficit. You know, their potassium is too low, well, let's give them some potassium. But until you've thought through what else it could be, probably better, because potassium given IV, for example, is exceedingly dangerous medication. So, you know, you just have to be very, very careful. And then, deficits can be reversed by giving it to the patient. Excesses are harder. You know, we can put something into the body, but it's hard to get it back out. So there are some tricks. You know, we can use diuresis. We can encourage them to pee it out using their own kidneys. We can bind it. There's a substance called K-exalate, which when given PO actually pulls potassium out of the body and then puts it in the toilet at the other end. Or just by reducing the input and letting the kidney have a chance to catch up and get rid of that excess. Acid-base imbalance is the hardest of the bunch. Oftentimes these are hospitalized patients, even ICU care patients. And you have to be careful to, again, not think too simply. Because it's easy to think, well, the patient's pH is low. Well, let's just give them bicarbonate, and then that'll fix the problem. And it doesn't. Instead, it just makes the problem worse. Because like in that example, sure, you can give bicarbonate, but you have to make sure that the patient is able to breathe fast enough to have it do any good, to actually get rid of the CO2. So they're tricky problems with tricky solutions is the short version. All right. So that's acid-base imbalance. All right. On to what I think is maybe more interesting. And that's congenital and genetic disorders. So we'll start right here on the first slide and say those two words are not the same. Congenital means you're born with it for any reason. Genetic means it's in your genes. So genetic disorders you will always pass on either as a carrier or, I guess not always pass on, but the genetic disorders are part of your genome. Congenital disorders may have been something that happened during development and have nothing to do with your genes. So we're going to talk about various different ones. So genetic anomalies, this is problems with the genome itself. So you can have single gene defects, you can have chromosomal defects, you can have defects on multiple genes, but the single gene disorders are kind of the easiest to understand. And first, a reminder, a gene is DNA that codes for one particular protein, and that one particular protein can have one or more functions. So when we talk about a single gene disorder, it's only ever going to affect one and only one protein. So because it was present in either the ova or the sperm at the time of fertilization, it means that this defect is present in all cells of that individual. So you can pick any cell and it's going to have that same genetic defect. Now it doesn't mean it will affect all cells, because a lot of genes are only expressed in one cell type or another. They're not expressed in all types of cells. So just because all cells have the disorder doesn't mean that all cells are going to express it. All right. Genetic single gene disorders get passed on to offspring following very rigid patterns, as we'll talk about in a minute. Non-reproductive cells can develop single gene defects. In other words, say a skin cell has had quite a bit of UV radiation from no sunscreen, it develops a gene defect. That defect will get passed on to the daughter cells of that cell, but it won't get passed on to the person's offspring. Because the only way for a genetic disorder to pass on in the offspring is to be in the gametes. So it would have to be a disorder in the ova or the sperm to make that happen. So normally, single gene defects, they wreck a protein. So they either make a protein not functional, partially functional, or do something strange, like we see in sickle cell disease, where in the presence of low oxygen, hemoglobin changes into a funny shape and tends to grab other hemoglobin molecules. So it's always about one and only one protein. So that's one class, the single gene disorders. Another class of genetic anomaly are the chromosomal anomalies. So in a way, you have to like zoom out. If a single gene defect affects just one protein, a chromosomal anomaly can affect many, many proteins, because a chromosome is a DNA package that contains many, many, many genes. Now, typically what happens during meiosis, which is the way that gametes are made, egg cells and sperm cells undergo meiosis. All the other cells undergo mitosis, just for that as a reminder. One of the ways that genetic traits are randomized or switched around, so to speak, is during that meiosis, the chromosomes pull apart, but then parts of those chromosomes switch places. That's called crossover. And every once in a while, that crossover process doesn't work right. And a chromosome ends up with 2 parts of one thing and 0 parts of another. We call those more complicated anomalies the translocation anomalies, and we're not going to talk much about that in here because it's almost over my head too. But you can have chromosomal anomalies and have normal numbers of chromosomes. Typically the most common chromosomal anomaly is Down syndrome, and it results in having 3 of a chromosome instead of just 2. But you can have chromosomal anomalies and have a normal karyotype or a normal pattern of chromosomes, but some of those chromosomes have mistakes in them, is basically the short version of it. Chromosomal anomalies are not as uncommon as you might think. So 7 out of 1,000 births, that's 0.7% of births, can have a chromosomal anomaly. At least that's what your book says. It seems a little high to me, but I have to go with what they say. All right. So then there's the congenital anomaly. So single gene defect, chromosome, congenital. And like I said right at the beginning, not all congenital disorders are genetic. Because there are lots of things that can happen between the time that egg is fertilized and the time that fetus becomes an infant at delivery. So it can be a problem during fetal development. Early or traumatic delivery can cause a congenital anomaly. For example, torticollis, which is a twisted neck, can occur with a traumatic birth if the brachial plexus is damaged. It results in a person whose head tilts to one side all the time. It can involve one or more than one organ. And then some genetic disorders are too complicated to give just one name because they call them multifactorial. In other words, it's not just one thing you have to inherit. You have to inherit, 2 or 3 things, and we're not really sure what those are. And then you have to be in the right environment to have that illness actually portray itself. So some genetic disorders and disorders in general have a genetic part, but then they have other parts too, an environmental part or things like that. So some of those are like cleft palate, where the hard palate doesn't seal up into one complete thing. It remains with a gap up into the nose. Congenital heart defects and heart disease are often multifactorial. As much as we know about the human genome, people still scratch their heads about some of those, like hypoplastic left heart syndrome and things like that. We don't know what causes it. Anencephaly is another one. This is a baby born without a brain. And again, it can run in families, but it doesn't follow the genetic rules, so these are the multifactorial ones. All right. So the first one we'll talk about are the single gene disorders. So this is, there are 6,000 of them known, and I'm sure that's hugely out of date. There are probably 20,000 of them now, because they're always adding to this list. The book says 1 in 200 live births. Many of these single gene disorders will present with no symptoms at all. In other words, the baby will appear to be normal and won't start to develop symptoms until later. For some single gene defects, they may never be recognized because the disorder is less severe or not severe enough to ever come to medical attention. There are some bleeding disorders that are like this, like von Willebrand's disease. Many people have it and they don't know they do because we don't all get our clotting times tested on a regular basis. Serious genetic defects usually don't result in an infant because if the genetics are messed up enough, the baby's not going to be able to develop normally. So the thinking is many miscarriages, spontaneous miscarriages, are probably genetic disorders that died in utero because the defect was so bad that the baby couldn't finish developing or couldn't even really start. Okay. Single genes can, it really runs the gamut. It can affect just one tiny little thing, like color blindness, or it can affect stuff all over your body, like cystic fibrosis, Marfan syndrome, some of the collagen disorders. And an important point to remember is that inheritance patterns are independent of the number of offspring. In other words, if you have a 25% risk of having a baby with cystic fibrosis, let's say, it's 25% with every pregnancy. You know, it doesn't mean that it's 1 in 4. You know, so if you have 4 kids, one of them will have it. Every one of your kids could have it. So it's just like the classic one that people mess up too, I think sometimes, is even if you have 4 daughters, your chances of having a son are still 50-50. So it doesn't ever get any better, regardless of how many times you try, basically, like roulette. So we divide the single gene disorders according to how they're inherited. So the autosomal recessive disorders, recessive means you won't display the illness unless you have 2 bad genes. If you have a normal gene and a defect gene, then you'll appear to be fine. So you are what they call a carrier. So the way we usually represent this is as big letters and little letters. So, you know, a person who's AA, let's say, that means that they have 1 normal gene and 1 defect gene. So they're going to be normal. But somebody who has 2 little a's is going to be abnormal. So because it takes 2 to make the disease, the transmission pattern or the risk of inheriting a disease from your parents, if the parents are here, let's just look at the picture. So let's say your parent is a carrier. Let's say both parents are a carrier. So big C is normal, little c is abnormal. So if you have to have 2 little c's to be affected, that means of the possible options, 25%, you have a 25% chance that your next offspring will have the disorder. You'll have a 50% chance that your offspring will be a carrier, though. And then a 25% chance that they won't inherit that defect gene at all. If, however, you have an affected parent and a normal, this is the most common case. So a parent has a genetic disorder, but the other parent does not have it, is not a carrier, then you get none of the children are affected. This is probably the most common pattern because it lets the species sort of store up backup genes without having them be portrayed in the population, unless something changes, in which case that comes around again. So like cystic fibrosis, I don't think cystic fibrosis is in there, but sickle cell disease follows this trait. I guess cystic fibrosis is. So see, there you go. All right. Yeah.
So the people that have that are carriers, they aren't going to know unless they have a second gene that's wrong. Like you have to have two.
The only way they'll know is if they've been tested for it, because they won't display any symptoms. The only other way they might know is if they have a child who has the disorder, because the child has to get one copy from both parents. So it says that both parents were at least carriers.
So for the percentage of people that are a carrier and they don't even know, that's the same percentage as the person that can have a child with it doesn't even know.
Right. And that's why these autosomal recessive, they tend to pop up in families and just randomly, because you don't know. You don't know who's a carrier.
But it goes it would go back and keep going back. So their parents, one of them would have both had to
Yep.
would have been.
Yep. You follow it all the way back. Now the problem is.
So you can have it be generations and generations before anybody ever.
Yes.
Does anything.
Yes, you can.
We should genotype all our future husbands at his expense.
And because the further you go back in ancestors, the more ancestors there are. So you have 4 grandparents, but you have 16 great-grandparents. It goes like that. So you're talking about lots of people, and at some point you lose track of who might have had it. Yeah.
This may be sci-fi thinking, but the way we adapt and the way the environment adapts and the way our cells adapt, we are at times changing the mapping. So if you say the skin messes up the mapping here, is it known to have certain diseases that we can become carriers when we were born without being a carrier?
That would require all the cells of the body changing, though. So
But maybe not all, because you're just talking about the cells that create either the ovum or the sperm. So it wouldn't necessarily have to be all of them.
I know exactly what you're saying. You're talking about feed-forward evolution. In other words, can the way we've lived our lives change the genes that we
Yes.
put forward into the future? Nobody knows.
Okay.
Why don't you do a research project on that, Karen?
I only have a year left.
What you do affects your sperm.
I'm sure it does.
I think it does.
Well,
I'm
lowers
sure.
the
Because
count.
it would be smarter that way. And if you look, this is totally off topic,
I'm
but
so sorry.
if you look at the male and female have 2 opposite reproductive strategies. The male makes huge numbers of sperm throughout their life. The female makes all of their gametes before birth.
It's the feet.
So isn't it interesting that we have these 2 totally different ways? And my thinking is, if one is smart in one way and the other is smart in the other way, so if you combine those 2, wouldn't it make evolution go forward faster? But no, there's no proof for any of that stuff.
Well, okay, so say that was true.
Uh-huh.
But so a woman, since we have it's done before we're even born.
Mm-hmm.
Nothing we do is really going to affect.
We're in theory land, but that's what I think.
Right. Well, guys do whatever they want, so there's something be affected.
Right.
So then it would just be their fault.
Right. But basically, it would mean that the female would bring in the past, what has worked evolutionarily in the past. And in theory, again, what the male would add is what would work better in the future or right now.
So we need him for
But
progression.
because
Yeah,
the
right.
female only
Right.
produces one egg,
Don't tell any of them that.
wouldn't it be more like that the female is there for survival? So if something's going to be smarter and adapting, it's going to be the female.
Oh, no.
Really?
From a genetic standpoint or
Yeah.
just from a chauvinistic
Yeah,
standpoint?
no, from a genetic standpoint.
Well, because the guy who's
All right,
just
we can move
guessing
on.
this might work.
If you're
in the
making
future.
thousands, I doubt that that's...
And tonight he applies for job 3.
Nah, I love it.
Okay, sorry.
All right, so autosomal recessive, autosomal dominant. This is the opposite. You only need one bad gene to show the disease. So these disorders are much more prevalent in like a family. Like you said, you can have a large family and not have a bunch of carriers. With autosomal dominant, if that gene is there, you're going to see it. So what we see is you only need to get the gene from one parent. So if you have an affected parent and an unaffected parent here, then 50% of the children are going to be affected because 50% are going to inherit that gene. If you have 2 affected parents, you're going to have 75% chance of having an affected child. So this is Huntington's chorea or Huntington's disease. Achondroplasia is another one that makes achondroplasia makes the bones not grow. It's one of the causes for dwarfism or little people, I think, as they like to be called. All right. And then the last one is X-linked, and this one is more complicated. And this is where the disorder is found on the X chromosome. And what makes that different is girls get 2 X's, but boys only get 1. So if the disorder is carried on the X chromosome, you're going to see it much more commonly in males because they only have 1 X. So they don't have a backup, so to speak. So what you see is a pattern like this. Oh, those are recessives. Hold on. So in an X-linked dominant, all the daughters of an affected father will be affected, and that's because, here's mom, and here's dad, and he's got the defect, right? So if we cross these, we get an XXD and an XXD. So if it's a daughter, they're going to be affected because they're going to get an X from dad. Now, for the sons, you're not going to have that because all the son can get is his dad's Y, which doesn't have the disorder on it. So you get all affected daughters, no affected sons. So because the no X is transmitted.
Unless it's the mom that has the defect, right?
Yes, if mom has the defect, we can work that out.
And so then with the mom, instead of her 2 X's kind of doubling down and making her more at risk, it's actually more of a backup thing because she has the other X, right?
Yes.
Okay.
Yes.
So do you see symptoms?
So hold on, we'll have a. So if mom has the disorder and dad doesn't, we're still going to have 50% of the offspring are going to have it, but 50% won't. So mom has the opportunity then to have an offspring without the disease. Does that make sense?
Mm-hmm.
Yeah.
Do you have an X-linked recessive?
Yes, that's coming.
Oh.
That's this one. So X-linked recessive, just what it says. So in females, it's only seen when the female is heterozygous or homozygous. In other words, she has 2 bad genes, 2 copies of a bad gene. And then in males, again, because they only have 1, it's seen more often. So if mom's a carrier, in other words, she has 1 defect gene and 1 normal gene, she's a carrier because she's normal, appearing anyway, because it's a recessive disorder. You have to have 2 of them. So 50% of the females will be normal, 50% carriers. It's just 50-50 all around. And for the males, 50% normal, 50% affected. But if dad is affected and mom is a carrier, let's see, we get these. I'm not a geneticist, folks, so in some ways I apologize. You're going to have 50% carrier, 50% affected. So dad can do nothing but give his defected genes to all the girls. Now, 50% of those would not be affected unless mom was normal, in which case they would all just be carriers. I guess not all of them. 50% of them would be carriers. And then this is where autosomal recessive really stands out, and that is 50% of the babies are affected, of the males are affected if dad is affected and mom is a carrier. All right, not my favorite topic. So when you look at this, at the pedigree here, what you see, and don't look too closely at it, but you can see that most of the orange boxes are affected, and you can see that here's 1, 2, 3, 4 males that are affected, and only 1 female that's affected. And that's what you see in these X-linked recessive disorders is in any given family, many more of the males are affected than the females are affected.
What was an example of the X-linked?
Duchenne's muscular dystrophy is one. Hemophilia is the most famous one of these, is X-linked recessive. And it got famous because of the noble families in Europe had an increased incidence of hemophilia. And one of the theories there is the nobles had such little genetic diversity, that you ended up with a higher incidence of those things. All right. So away from genetics, please, because that's
I love genetics.
been a long time for this old guy. It's a stretch all the time. So you guys just had it, so it's all fresh and clean in your minds. All right, anyway, chromosomal disorders. So those single gene defects affect just one little part of the DNA. This is really something you could see happen if only you could look under the microscope and watch it, because chromosomes form inside the cell that's about to divide. They then split, and one of each goes to each of the daughter cells. At least that's what's supposed to happen. But sometimes there are errors. So if instead of splitting nice and evenly, you get 2 on one side and 0 on the other, then you can get trisomy, for example. And this is where instead of having 2 copies of the chromosome, you've got 3, and it's chromosome number 21. So the normal human being is 46XX or 46XY. 46 is the number of chromosomes. Now there's 2 pairs, so it's really 23 plus 23 for each of those. So in the trisomy 21, on one set has an extra, so you get 24 plus 23. So that's a trisomy. A monosomy occurs when you didn't get one. So instead of having a 24 and a 23, you'll have a 22 and a 23. So this means that you don't have a complete genetic set. You're missing one copy of a chromosome. Now, these are still compatible with life a lot of times, though. In other words, the patients do get born and they do live into childhood because they have all the genes, they just don't have the extra copy of one of the chromosomes. So they're lacking some variability, lacking some diversity. And then polysomy happens in the sex chromosomes, where instead of having an XX or an XY, you can have an XXXY. You can have actually many X's in some disorders. And then there's one disorder where it's an XO, where it's all that girl has is an X, doesn't have a Y. All right. Okay, let's do a question. What is characteristic of a congenital disorder? Hold on, did everybody put your number in? I don't think so, because I only got 9 responses. Here, I'll leave it up. Go ahead and put your numbers in. We have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 12. I got 12 in the room. Anybody not getting logged on or not?
Oh, wait, maybe it kicked me off because now it's asking for my room number. Oh,
Can't
it's
try
right. It's waiting for you to start the activity.
The student number one?
Nope.
No,
Room number.
it wants, I need the question.
Okay, I got one more person who needs to answer. 1, 2, 3, 4, 5, 6. Who's number 7? I'm missing 7 and 9. Shayna, did you get in there?
I can't, it won't let me. It just says room number, please wait for teacher to start activity, and it's supposed to be spinning around.
Mine
Yes.
says the same
And it
thing,
doesn't
did not
do
accept my number 10.
No, I have you.
Did you shut the room number?
No, click on room number. It won't do anything.
Well, I don't
Oh,
know
it
what
just
that
added you to the room, though.
Oh.
Because the room count just went up. There we go.
Who, what?
Hold on, I just got another number. 4, 5, 6. I still don't have 9. I just picked up number 13.
Is your thing spinning? See, your thing is spinning, mine won't.
Are you on the app or are you on the web?
I'm on the web.
Huh. Well, I know you're here, so we'll go ahead. This room is not the best for this. All right, so first question, what is the characteristic of a congenital disorder? It's finally raining, I think, folks. Did you get the next one, Shayna?
No, it wasn't working yesterday either, but before it was,
Huh.
like last week it was fine. But no, it just doesn't do anything.
It's locked. All right, well that's 11. All right, so
If I could open mine,
we'll get there. So characters, yes, D, usually manifested in the neonatal disorder. So genetic component, possibly, but not necessarily. Developmental anomaly, that's one possibility. Cause is known. Oftentimes, congenital anomalies leave us going, we have no idea why this happened, but this is what the baby has, and this is what we have to do with. But typically, yes, it's going to be manifested in the neonatal period. All right. So, a good old probability one. What is the probability of two parents, both carriers of a defective recessive gene, producing a homozygous child with each pregnancy? In other words, an affected child.
I didn't realize neonatal encompassed utero.
It doesn't.
Well then,
Yeah, it does.
how is that answer right?
What?
In this text, it does.
Neonatal doesn't
Congenital disorders usually present after the baby, immediately after the baby is born.
present. What was the wording of that question though? Did it say present? I couldn't write it down.
What is a characteristic?
So is it because I guess manifested? I took that as when does it happen?
Yeah.
No. A manifestation is when do we see it?
Because I picked the last answer, or I picked in the birth B. I picked B.
Yeah, it's a development. Yeah, manifested is when do we see
When
it?
we see it.
Mhm.
Okay.
And we're not gonna see it, most things until it's born anyways.
Right. I mean, yes, you can pick up a congenital anomaly in utero, but only with tools. You know, only with imaging and stuff like that. All right. Everybody got their boxes done?
No.
So we have two carriers. So we do the cross, and we get that. So what's the chances of homozygous? These are the two homozygous states. One is absolutely normal, not a carrier. The other is affected. So we've got a 50%. So the answer there would be C, 50%.
What? Go back.
What?
Homozygous.
Homozygous. That means two of the same.
25.
Well,
Those are the same. They're both homozygous.
they're both
One's
homozygous,
one's
so there is a
dominant.
50%
But
chance
defective.
of having a homo. Okay, that's a confusing question.
Carrier
Of
of a
25.
defective
It should
recessive. say
say homozygous and affected.
Oh.
So 25.
Yes, so 25. No, please check my genetics math, because like I said, I'm bad at it. All right, in the case of an X-linked recessive disorder, a carrier mother and an unaffected father could produce which of those things? I got to send you the next question there. So, what do you call those squares again?
Punnet?
Huh?
I call it a punnet square.
Punnet. Yeah, that's it. Carrier mother and unaffected father. All right, so what could they have?
All normal kids.
X-linked recessive disorder.
And they could have a male carrier.
They could have all of them.
Hold on.
And they could have, no, they're not gonna have an affected female.
We're going to call it N.
Oh, because she's got the extra X. I see what you're saying in that top. Okay, you're right.
XD, XN.
I keep
So
forgetting
that's a
that extra is
carrier.
backup plan, not a invisible trait.
Okay, so could have a normal female, yes. An affected female,
No.
no. And a male carrier,
Yes.
you can't have a male carrier in a X-linked recessive because there's only one option. That's
But they
affected.
chose to carry- they-
No, because the one next to
Yeah,
it's
so
not
he
affected.
carries it.
He wouldn't carry it, he would express it. Because he only has the one, so he would be affected, not a carrier. He'd be an affected male.
But on the top, then the female doesn't have 2 affected genes.
It's
She has 2
recessive.
carrier
It's
genes.
not dominant,
Right.
it's recessive.
Right. What I did is
You
let's.
put dominant though.
I need your square to be bigger.
Don't do this to me.
He's a carrier, his daughter will be.
There we go. So we'll call it X normal and X abnormal. How's that?
No, because it's
Just
recessive.
X.
It's gotta be a little R, it's recessive. That's
I'm
why.
trying to make it simpler. So how's that? So we have a carrier mother and we have a normal XN father, right? All right, so we're going to have one normal female.
Happy face.
We're going to have one carrier female. We're going to have, let's see, he'll get an X and a Y. We'll have one normal male, and then we'll have one affected male.
Affected male or carrier male, because it's.
He has it as affected.
He has to be affected. He can't. A carrier has to have one of each, and he only has one. So he's going to be affected.
So they would
Oh.
have a normal.
So the right answer there is the only thing that they could actually make in this list is a normal female.
But to be recessive, don't you need 2 of them, so a male will never be a carrier?
That's what makes X-linked different. Because there's only one gene, you don't have to have
The
2.
males show it more often than a female.
Right.
They will always
So here's where I think, in order to have a recessive disorder, it's not that you need 2, it's that you can't have a normal one.
Okay.
Does that make
So
sense?
Is this like, okay, because one of your charts kind of confused me. Not the ones that you drew in here.
So does this mean you'll
Shane's
never?
muscular dystrophy. That's this. Because a female doesn't ever really present it, but a female is always a carrier. That's because she has that extra.
X-linked recessive disorders. So you can get an affected female, but you have to have an affected father. So a normal father,
Really rare.
Right. Exactly, because let's face it, when it comes time to have children, you don't want to have an abnormal child, or you don't want to have a child
Well,
with
if
someone
your
who's
dad is
abnormal.
affected, you're not going to have sex with
That's the truth of it. Yeah.
I see what you're saying. So
You know-
you'll never be a male carrier because a male carrier will always be affected.
Correct.
So you will never get the recessive trait
Correct.
from the male because if you're having sex with that male, it's going to be pretty obvious that there's something wrong with it.
Right. That's why most of the X-linked disorders don't become fatal until later on in life, because otherwise they would drop out of the population. So,
Oh, so you don't know if the guy's affected till late.
depending on what the disease is, if it's Huntington's disease or whatever, that doesn't present until later.
So if I wait till like 25,
You're working your own little eugenics thing,
I'm
aren't you?
taking only male. You're my chance to go down. Then I have to deal with this rusty sperm. He makes me one. He makes me one.
Yeah, but he's still old. Maybe
Well, I
do
know.
that.
I still gotta deal with that side effect. And then,
All right, where are we in our thing here?
trying to create genetically superb babies.
All right, let's talk a little bit about developmental disorders. So those are all the congenital things, are all the genetic things that can go wrong. So what are the other sources of congenital problems? One of them is developmental disorders. You know, when you stop to think about it, it is amazing that that single fertilized cell can do all of its changes and, divisions and eventually end up, that 7-pound, 6-ounce crying baby boy or girl. There are lots of things that can get in the way of that process. So there's a whole class of chemicals called teratogens that affect fetal development during pregnancy. Now, of course, we don't know what all of these are, and sometimes we discover new ones. But typically, and we'll go over a list here in a minute, the earlier the exposure to the fetus, the more significant the effects. And that's because the first 6 weeks after fertilization, the baby undergoes very complex changes that have to be just perfect in order to be normal. So teratogens early on can result in even a fetal death through abnormality. Not all developmental abnormalities do we know the cause of, but anytime there's evidence of an effect of some substance, a teratogen, people try to take that out of the equation. In other words, try to prevent exposure to pregnant women. One of the tricky spots is pharmaceuticals. New medicines are being developed all the time, and it's not ethical to test teratogenicity. In other words, how teratogenic is a new medicine? Because of course it's not like you can give that medicine to women and see what the results are. I mean, if you don't know, you shouldn't be doing that. So there is a very short list of medications that people are comfortable giving to pregnant women, particularly in those first few months of pregnancy. And most of those they've been around for long enough that the number of women who have taken those medicines while they were 4 weeks pregnant or 6 weeks pregnant is great enough where people aren't worried about it. So some known teratogens: alcohol affects brain and facial development as well as overall body size. Cigarette smoking is known to cause low birth rate and an increased risk of stillbirth. Radiation is a known teratogen. If a patient is pregnant, the methods we have for treating a cancer, for example, are almost nothing because practically all of the chemotherapeutics are teratogenic. So it's a tough ethical and personal decision for mom there. Pharmaceuticals. The most famous teratogen ever is thalidomide, and its story is absolutely tragic. And that's because thalidomide was an anti-nausea medication. And if any of you have been pregnant or know somebody who has, nausea is very common early on in pregnancy. So at the very time when the baby was most sensitive to teratogenic effects, thalidomide was being used to treat morning sickness. So there was a whole bunch of, they call them thalidomide babies, all born within 10 years of each other because basically medicine didn't learn that the thalidomide was causing the birth defects until there were already many, many babies with that birth defect. And it was limb abnormalities, deformed and very short limbs that didn't work right. Cocaine is a known teratogen. And then the torch infections, which we'll pick up on when we start next time. These are infections that are known to cause fetal abnormalities. So at the beginning of a pregnancy, all women who seek prenatal care anyway are tested for all of these infections because if they're present, it's best to treat them as early as possible. To not treat them can lead to developmental abnormalities. So it's toxoplasmosis. I love this one, other, which is Hep B, mumps, rubella, varicella, gonorrhea, syphilis. They should make a mnemonic for that. Rubella, which is German measles. Cytomegalovirus, CMV, is common but not symptomatic, so you have to check for it. And then any of the herpes infections. So these are all tested for as part of that first prenatal care visit. They'll test you for them if you go in before you're pregnant and say you're planning on becoming pregnant. They'll do the torch test then too. All right, so let's stop there because it's time. I like it when you guys ask questions. It makes it much more fun.
Thalidomide, was that Germany? I know last week Germany just
Oh,
sent out a...
it was America too.
What did Germany make? They made a drug and they just sent out a mass, like a thank you, or I mean a sorry. They made a drug that was used like 50 years ago and they're just now admitting you screwed up all your pregnancies.
Yeah.
Thalidomide
Well,